Okay. Uh, this is the first Zoom session for HIS 160. Today is September 7th. The main thing that I look at is concepts. If you understand it, if you have a working idea of what is needed and what you need to do, I'm fine with that. Ask me questions. If you think something doesn't make sense, challenge it. I don't get, well, this is the way I learned it, and that's the way it's going to. No, I am very open to new ideas. If you've come across something that corrects something that I learned years ago, fine. I mean, if we go back, some of the things that when I was in grad school, which was, I mean, we used to have to hit stones to get the lights going. Yeah, I'm old. The original cochlear cross-section studies were only done on cadavers because we didn't have the CAT scans, the MRIs, all the other things that we have available now, where we can do real-time studies of motion of the waveform inside the cochlea on a living person. Everything was post-mortem. So it's changed a bit. As a matter of fact, when I was in grad school, tympanometry, impedance audiometry was just introduced to this country. Yeah, it was that long ago. And it was great. I mean, we did studies that nobody else did. I was at West Virginia University for that. So I think someone has their volume up just a little high. We got a feedback going. There we go. If you have trouble hearing me or something else is going on, just let me know. I talk louder. I'm a trained stage performer, so we'll get into that. Yeah, later on I'll post some pictures of. I was Uncle Fester in Addams Family about 3 months ago. So throwing back. Anyway, I don't get upset when somebody challenges. I would rather have you ask questions. I would rather have you get involved with it. And if you catch me in a mistake, all the better, because hopefully I won't make it again. So be aware of those things. Be willing to say things and do things. I'm pretty easygoing. I don't like failing students. Not that I don't like the student, it's just I don't like failing them. I'd rather have you, I mean, if it's something that you are not really going to get the grasp of what we're covering, I'll be talking with you privately. If it just doesn't make sense, or you have a late assignment, I mean, like right now, we're packing up things and we're getting ready to head north to get out of Florida. So I might say, I don't have time to turn that assignment in on Friday because I'm going to be on the road. If you tell me that, I'm fine with it. I mean, life does not run smoothly, and I think all of you know this. Some of us more than others, but yeah, things don't always go the way we plan them. So let me just see here, because again, when you get my age, you need reading glasses. I make a lot of reference to my age because I'm really old.
I'm there with you.
Oh, you're a baby.
No. A new career this late in life is tough.
Yeah, I know. I'm still trying to get a paying gig for voiceover or stage productions. Let's see what we got. Share screen. Link. All right. So let me do this. We'll close that down. Close that down. I'm going to put this over here. Okay. For reference, I'm going to, I'll probably end up emailing everybody, but materials, and I know a couple of you haven't had the course, I think it was 140, where they were covering components, parts of the hearing aid, battery sizes, things of that nature. So I'm going to try to send you, I have one file on cross-section of the battery, gesundheit. I have some suggestions that were formulated by hearing impaired people, battery capacities, things, a closer look at a breakdown of the hearing aid. It's a PowerPoint presentation. So you're going to have all of these, and that is going to probably be more than enough for the review section of the quiz. So, you know, it's basically, it's nice for me to say, okay, here's infection control. But if you don't know the parts of the hearing aid and you don't really have the background to do that, you can't worry about the infection control when you have to worry about what part am I unscrewing. So this is part of it too. I want you to understand the difference between a microphone and a speaker, and why you know, there's developments in a lot of different areas that are happening now that were inconceivable when I was first starting out in this. I mean, you know, some of this stuff, having computerized hearing aids, having digital hearing aids was a dream when I first started in this. I mean, our major adjustment tool was a jeweler screwdriver. And now we have computer adjustment where we can change output, gain, adjust frequency response, adjust slope, adjust attack time, release time on the compression, link it up to the web. I mean, these things were unheard of. I mean, it's nice when you're walking down the street and someone's talking to themselves and you realize they're actually talking on the phone with their hearing aid. So instead of just talking themselves, we have people like that. Anyway, all right, let me get this up. I'm going to open up my PowerPoint. Okay. So you will be getting both of these probably emailed to you very shortly, because again, I was hoping I'd be able to just send these to you like we did with Blackboard, but this is my first semester with Canvas. Okay, let's go share screen, and there we go. Yeah, you guys can see that? Okay. Here we go. All right. That's a nice clear image, isn't it? Implantable hearing aids, and even they have gone beyond this. There's a number of different types, but bone anchored, which has often been referred to as BAHA, middle ear implants, which are attached to the ossicular chain in many cases, cochlear implants. A lot of people, a lot of patients that come out there think that cochlear implants mean that they're giving you a brand new ear. If we could transplant cochlea, it would be nice. Brainstem implants have worked with patients that have no cochlea, or the cochlea are so ossified, so bone structure, that they just can't. They just can't have the implant put in. Traditional hearing aids, there's two main types: air conduction and bone conduction. On the standard hearing aids, the air conduction hearing aids, there's the behind the ear, the RIC, and you can see the RIC is designated into two areas. Over on the right hand side it says receiver in the canal and receiver in the ear. That's because this wonderful field, every manufacturer tries to have their own terms. So you have a RIC, which I prefer, receiver in canal, or right. The problem I have with the right is when you're designating that you have to order a right or a left right. To me, that's confusing. ITE, ITC, CIC, and the new IIC, the invisible in the canal that goes all the way down, are all the different types. I'm sure most of you are familiar with that, but we're going to be taking it step by step. Bone conduction, rarely used today, eyeglass and headband bone conduction. The BAHA has been added to that. You're all familiar with these different styles of aids here. And again, you're going to be getting this for review. I'm not going to be going, all right, tell me the difference in faceplate surface area between the mini canal and the ITC. No, I don't do stuff like that. As long as you know that the CIC is the smallest and the ITE is the largest, and you know what the order is of the ones in between, you're fine. Okay. I still remember one lecture I attended years ago where someone says, you know, we have all these ITC, ITE, BTE. Just remember, you don't want your patient to have an ITD hearing aid. Does anyone have any idea what an ITD would be? In the drawer. Yeah. There's a lot that end up there. And then they go, these things are no good. Yeah. Hearing aid effect, this goes into, I mean, you don't have to really get into the standard deviations and all this. This is just for reference. This is showing the difference in the amount of visibility, you know, from in the full shell in the ear to the you know, in the canal. You know, there's a number of different ones. This I'm more concerned with. This is basic. This is what we work with. Power source, whatever the power source is, 99 out of 100 times, it's a standard zinc air battery. People are going now to the silver zinc rechargeables. So there's a lot of different things that are happening. One person told me he was developing a solar powered hearing aid, a power source, and you'd wear the hat and the thing would be on the brim of the hat. He says the only problem was it didn't work in the movies because it was dark. Never mind. All right, don't worry, they get worse as the semester goes on. Digital sound processor. Digital sound processor, it's a computer. What it's doing is taking the sound wave and converting it to points, zeros and ones on a graph. And it just does that automatically. This gives us the flexibility of making a lot of changes. The receiver is the speaker. Why the receiver, which we would think is receiving the sound, is actually the speaker giving you the sound. That's the way it's always been. So the receiver is the speaker, the microphone is the input. These are the basic components. Batteries, three main types: silver oxide. We usually have those now for watches and certain other things. Mercury batteries are no longer available in the United States, except in rare instances. Mercury hearing aid batteries have been outlawed since I think it was the 80s, was when they were trying to get mercury out of everything. Zinc air, when you peel the tape off, and if you can see where it has the H, G, F down along there, you'll see, I think F is the air hole. Yeah, there's a little bit, there's another one over, whoops, as I slowly change everything. Here we go. And you can see can you see my cursor when I move it? Okay, good. So you can see here, there's another air hole. Some companies have 3, some have 2, some have 1. That allows the air in, so the chemical reaction begins. The zinc, once it's exposed to oxygen, begins. I've had patients who would put the tape back on the battery to try to save it. It takes 48, once the air gets in, it takes 48 hours for it to stop and go back to a dormant state. So they're not going to save the battery. The nice part about the zinc battery, it has a fairly flat, it doesn't slowly degrade like the mercury or the silver batteries, where it's better on the first day. Yeah, we've had a lot of people who think that the batteries, kids eat them because they think that they're candy. You want to keep it away. If the gasket between the two components, the two materials, breaks down in the stomach, you can end up with gangrene of the small intestine. I mean, there's a lot of problems you can have. You want to have them removed. Let's see what we've got here. I don't think we really need to go into this. Don't induce vomiting. Poison control. Basically, you want to have the kid at the doctor and in the hospital and get it treated. It's not one of those things where you let it just pass. Microphone, breaking it down, the diaphragm. You have the air above and below. So there's air up here and air down here. The sound comes in, changes the shape of the diaphragm, which the differential between the diaphragm being closer to or further away from the other plate gives you the sound, because it varies the voltage. So here again, you can see you've got the plate, the diaphragm moves. When it moves, the distance from the plate varies. When that distance varies, it creates a voltage differential, which gives you sound. Early directional microphones had 2 openings. There was a filter in the back one, so this would arrive slightly later than this sound. This would change the amount of differentiation, of distortion in the diaphragm. This is what the directional microphone is supposed to do, give the ability to directionally place. What we have found that in most cases, the directional microphone gives you front to rear advantages for noise and directionality. It doesn't necessarily give you the ability to pinpoint unless you have binaural function. A single directional hearing aid does not work as well as 2 functioning ears. And again, as I said, I'll be sending you these. We have this on the recording, but I'll be sending you these as well. Troubleshooting the hearing aid, broken microphones, things of this nature. Listening to the T-coil buzz. A good way to do that is TV screen, a few other things, but getting a buzz is the best way. This is the speaker driver. It's like a piston. It drives the plate electronically by the signal that it gets from the amplifier and the processor. That drives the foil, which converts it back to an analog sound. I'm basically giving you a semester here in a very short period. This is about as complex as it can get. If you look at it, this is more of a fun drawing than anything else, but it shows you what can happen logically and where everything's going in order to get the sound come from a digital to an analog. The sound comes in through the microphone as an analog system, 1-to-1. It comes in. The analog to digital converter converts it to a digital signal for the computer to process, because it can process math a lot faster than we can. That's the stuff that happens. The digital then goes through the amplifier, it's processed, then it goes back to a digital to analog converter. It's converted back into an analog sound. It's presented to you. This is some of the stuff. Again, review it on your own. If you have questions about it, shout, whatever. These are waveforms. Matter of fact, I saw a very interesting use of the waveform. There was a couple that when they got married, they took the waveform for each of their voices saying "I do" and had it engraved in their wedding bands. So they actually had "I do" on the band. I thought that was kind of cool. Anyway, but then again, I'm kind of geeky anyway. We won't get into that. High frequencies, low frequencies, it depends on the type of sound wave. Give you an idea of sound waves. The higher frequencies, since they occur faster during the same period of time, waveform is shorter. So low frequency sounds have very long waveforms. High frequencies have very short. This is why you can block high frequency sounds very, very easily. But the low frequency sounds are the ones, if you're trying to do a hearing test, 125 and 250 are usually the frequencies you're not going to be accurate on unless you have a really good sound booth, because you're going to get noise pollution. This is a child with atresia. As you can see right here, the ear is not formed. The ear canal probably was malformed. Using some type of this one has the pickup and amplifier and everything, and it brings it around to the vibrator on the other side. By vibrating the skull, it creates the sound wave in the cochlea, and the patient can hear. As you can see here, and again, these are masked bone conduction. It's normal. Air conduction, bilateral conductive loss. On this particular patient, if there's something which cannot be medically or surgically corrected, bone conduction does help. Cross contralateral routing of signal, which basically means you put it in one side and you hear it on the other. So you're taking the sound from the bad ear and bringing it around to the good ear. There is a difference in sound between the good ear picking up the sound on its own and the amplified sound. So the person can learn to locate directionality, and it will help in certain instances. Long-term dead ear, patient has only one functioning ear. Over a long term, if they've learned to use that to their advantages in different situations. So fitting somebody in their 50s or 60s with a cross, when they tell you in their history, yes, I've had a hearing loss on the other side, that ear's not functioning. It's been that way since I was 8. They're probably going to not be a good candidate for a cross. Because instead of turning their bad ear toward the noise source in order to quiet it down so their good ear can pick it up better, the cross hearing aid is going to bring the noise source over to the good ear, even when they put it, turn their head away. So that can work out as a problem. This would be someone that might work well with a cross, but again, the history has to be taken. And that pretty much covers that 3 weeks of a course. All right. Let's see. I'm not going to go through the other not going to give you the other PowerPoint. I'm going to send that to you rather than try to cover it in our time frame here. These are things that were designed by hearing impaired people, which I think are probably some of the most effective posters to have in your office for family members to realize how the hearing impaired person is functioning. Because everybody is, well, why didn't you hear me? Well, gee, I thought I was talking clearly. I don't know why you're having a problem. This is it. And it's obvious for them, but not real. So, let's see what we got here. And so, did anybody have any questions on the review material? I get a lot of shaking heads. Okay, good. Talk. I'm here. I can hear you.
Mr. Segal, this is from the last course, right? 140?
Yeah.
Okay.
Because basically, this is the stuff you need in order to know why. Why are we concerned about ear infections? Why are we worried about cross-contamination in the office? Okay, basically, let me see if I can get out of this. Close this. I love it when everything kind of covers itself up here. Okay. Anyway, one of the things to be aware of is prior to the AIDS scare back in the 80s, nobody wore gloves. Nobody worried about cross-contamination because what are we dealing with? Ear molds, hearing aids. How bad is a hearing aid? Well, when you take a hearing aid and it's coated in that oil and wax and you clean it off, take a tissue and clean it, and you're holding it with your bare hands. Yeah, wax is wax. It was considered basically an inert, not sterile, but fairly safe material unless the person had active drainage. Well, we discovered something. Sometimes there's blood mixed in with that. Person cleans their ear with a Q-tip. They scratch the surface of the ear because a Q-tip is basically a very fine steel wool kind of material. And that's what we're doing. Now, if we get cut off on this because they have a time limit on these things sometimes with the Zoom sessions, don't worry about it. I'm not going to jump up and down either. So anyway, let me go back to this. Here we are. But when we started realizing that there was wax, that there are other things like you're working on one person's hearing aid and they are diabetic and they have a fungus infection in their ear. And you wipe, okay, and you pick up somebody else's hearing aid. You've now given that person the risk of a fungal infection in their ear. And if they're diabetic, they have a higher rate of infection because the system is not working properly. So we have to be aware. We have to be aware of how to take a glove off. You don't just grab and pull and then grab and pull because you're touching. If you're taking the glove off, one hand, you would go underneath and pull. And as you pull, you're taking this glove off. And then you would go back here on the other side and pull it off. So basically, you're turning them inside out, putting one inside the other. Toss them. Then wash your hands. If you don't have access to a sink right there, use the sanitizer. Sanitizer does not get rid of debris, does not get rid of gunk on your hands, but it'll kill a lot of the bacteria and a good number, depending on what you're using, of the viruses that are able to cross-contaminate. The other thing is, this is to protect you. You're protecting your patient, but it's to protect you. I had a friend who worked with patients for years, and one day she didn't wear a glove. She got cellulitis. Her index finger on her right hand swelled up. It looked like a salami. She was miserable for weeks. And it did that within one day. It was within 24 hours it swelled up like that. Now, why? She must have had a scratch, a break in the skin. It got in there. Her system reacted violently. We don't have to get in. Plus, if you really want to go into some of the old-time dispensers who, and I know one person who still does this, and I get grossed out every time I think of it. When they would go to put the hearing aid in the person's ear, and the fit was fairly tight. Now, normally you take a little KY jelly or a little Odo Ease or some of these other things to help slide it in. Well, they would do this.
Oh, gross.
Gross? Yeah.
Gross.
Or they would, I had one patient, their vent was clogged. And I said, the vent's clogged, so the air's not getting in. And he went, oh. I was like, oh. Yeah. You have to be careful sometimes that you don't make faces like that when the patient's right in front of you. You go, I really wouldn't recommend doing that because there's a possible. You have to be the professional. They will do things that surprise you. But the person helping another person by taking their hearing aid and doing that really grossed me out. And I know somebody who still does that. Anyway, we should use things like, in my office, I had a procedure. A patient brought a hearing aid in, the person in front office, if they're saying, I'm just dropping this off so Dr. Siegel can work on this. She had little battery envelopes or bathroom cups, and she'd hold it out, put it in there, and then she'd give it to me. I'd have gloves on when I'm working on them. I had my lab bench. I had a dental tray, the paper that went into the dental trays. All my work was done on that. If I don't have that, I have a paper towel. I don't want to put it on the surface that I'm working on because then the next one I put down, I'm going to have to clean the surface and disinfect it before I put the next one down. If I just put it on top of that. Wipe the hearing aid off. Use a disinfectant to clean it. So besides the fact that you're cleaning it, which gives you a better ability to visualize what's going on with it, it's cleaner. And it's going to help both the patient and it's also going to help you. Then when you go through the troubleshooting, you're going to be able to do that. The other thing that you get into the habit of is when you're wearing gloves, you don't do this. You'll do this. You don't want to touch this surface to you because now that's contaminated. This is not. So if you do have an itchy nose, you can still do this without possibly infecting yourself. There's a lot of things you can catch from people. And you also have to be aware that it's not always just wax. It can be wax and blood. It can be wax, blood, and spit. I mean, there's a lot of things that you have to look at that patients do to hearing aids. You also will find things like someone brought in a custom ITE. It was his mother's. He said it's not working. I took it in the back, and again, using my standard, I put my gloves on and I'm opening it up. And I also was trained, so I take a razor blade and I